Okay, let's get started then. That's 4 minutes past the hour. So welcome everyone to this webinar on the second Vital Signs Partnership report, which is on migrant workers' access to health. A little bit of housekeeping, I guess. If anyone has any questions, could you put them in the Q&A box, and then the panelists and me will see those, and we can prepare those either for the end of the Q&A, or we can interject them in between various speakers. So it's really a delight to do these things, and I'm so pleased to see the names at the bottom of this opening presentation. Remember, this is a partnership, a coalition of NGOs working on this issue. We have Lapsoj in Nepal, we have Justice Project Pakistan, we have the Centre for Migrant Advocacy in the Philippines, and we have Rumru in Bangladesh, and Fair Square, which is, I guess, a sort of coordinating organisation. We've been working on this issue for a long time, and it's great to be in this partnership. I'm going to quickly give you a brief overview of the project as a whole, not just this second report, but the second report has to be set in the context of the first report and the purpose of the overall project. The purpose of the overall project is really to try and garner more pressure in origin states on this issue. We know that thousands of migrant workers from Asian origin states die every year in the Gulf. Unfortunately, we don't know how they're dying, and we don't exactly know how many are dying, although our first report did place some answers around that, I think. And it's an attempt to get origin state governments to make calls for better protection which would protect lives, but also protection that would ensure better labour rights for migrant workers going across to the Gulf. So if we go back to the first report, which we released in March this year, we focused heavily on trying to ascertain what data existed on this issue, and what did it tell us? And what it told us that as many as 10,000 migrant workers from South and Southeast Asia appear to die in the Gulf every year. And they're dying from unexplained causes. More than half of them are dying from unexplained causes. What do I mean by that? Well, I mean that death certificates say things like natural causes, or acute respiratory failure, or cardiac arrest. Information that gives you no actual information as to how the person stopped dying, whether it was a disease or an illness that was at the heart of it. And families don't get answers, and of course, families don't get compensation. When we looked at the data, we found that it was fragmented, it was incomplete, it was inconsistent. Not one origin country's data looked similar to any other origin country's data. Similarly, in the Gulf, not one Gulf state's data looked similar to any other Gulf state's data, which means there's an absolute inability to compare and contrast and look for trends and look for anomalies within the data that might provide public health experts with some clue as to why these workers are dying, and therefore to try and propose solutions to those problems. The report also looked at the various risks to which migrant workers are exposed in the Gulf, and it found that there are cumulative risks to their health: heat, humidity, air pollution, overwork, abusive working conditions, poor occupational health and safety practices, psychosocial stress, and the impact of things like recruitment fees, and the impact of things like living in dreadful accommodation and having the stress from your family back home who are waiting for money, the impact that can have on your body and your mental health is too. We looked at things like hypertension, and then we looked at specific issues like chronic kidney disease, which many health specialists think is an emerging global problem in intensive labour sectors where heat is a problem for the workers involved. So that was the first report. Now, the second report, we had to, as a coalition, come up with a sort of thematic study that we wanted to look into in more detail. And the issue we alighted on was access to health. And why did we do that? Well, it was the one where we felt it was under-researched, where there wasn't enough detail on it, where there was enough evidence to suggest that migrant workers were having problems in actually getting access to these tremendous healthcare systems which exist in the Gulf. But we needed to more definitively research the problem and come up with a better sense of just how acute that problem is. And so the second report is that research, essentially. How do we do the research? Well, we were very fortunate that we had a survey of more than 1,000 low-income workers in Kuwait commissioned, and the Kuwait Aid Network did that work for us, and that produced some really interesting results, which I would summarize as saying migrant workers have extreme difficulty in getting access to healthcare, not because the healthcare doesn't exist, but because often they don't have proper documentation to get access to that. We did detailed field research in the Gulf, particularly in Saudi Arabia and the United Arab Emirates, and our partner organizations did extensive research in origin countries as well. And of course, because this is a report about health and we're not health specialists, we drew on the expertise of medical and public health experts, predominantly from South and Southeast Asia. It's a big report. It's a 46-page report, and I hope people will have the chance to look at it in detail. It has a particularly large executive summary, I would say, which is where we bring everything together, and it does give, I think, hopefully a fairly readable assessment of the problem, bringing together all the various strands from the various chapters in the report, which in a sense are all standalone and can be read in isolation. The executive summary is where I think we bring that all together. What does it say? Well, essentially, because you have all these risks for migrant workers, because they're exposed to so many risks, what you need is a healthcare service that is tailored to those specific needs. Now, what we found is actually there is no specific tailoring to the specific needs of the most vulnerable sections of the migrant worker or of the Gulf states populations. In actual fact, what you find is that there is indeed clear evidence of discrimination in access to healthcare. I.e., it is a migrant workers, the fact of being a migrant worker makes you less able to access the healthcare that you need than, for example, a Gulf national or a wealthier expatriate migrant worker. That was the key finding, I think, based on, it probably doesn't come as news to people, but it was good to have the survey to definitively identify that as a problem in Kuwait. And the trends identified in Kuwait were in evidence elsewhere in the Gulf, of course. Now, the second finding, I think, might seem obvious, but the inability of workers to access this healthcare has a detrimental effect on physical health, has a detrimental effect on mental health, and it is likely that it is a significant factor both in the number of preventable deaths, i.e., if you can't get access to a doctor, you're more likely to get sick, and you're more likely to get sicker. Preventable disease becomes a serious disease, and a serious disease can become an untreatable disease. But also, it's likely it has a significant impact on the number of preventable deaths. The number of unexplained deaths. Remember, the number of unexplained deaths in the Gulf runs at more than 50%. Access to health is probably not the key reason why that is the case. The key reason why that is the case is that the Gulf states generally do not do investigations into migrant worker deaths. But a critical part of that is when migrant workers come in to healthcare services, either dead, unfortunately, or in a serious medical condition, doctors are going to look for a medical history for that worker. If no medical history exists for that worker, and they have come to the hospital too late, it's going to be very difficult for the physicians to determine or to even approximate what that cause of death would have been. So it's not just about access to healthcare causing deaths or leading to deaths. It actually is a significant, it's a factor in also why the unexplained death rate is so high, according to the doctors we consulted about this. A third finding, and we've got someone who's going to talk about this in more detail, is that the gradual shift in the region to mandatory health insurance, mandatory private health insurance, is likely to be a further barrier to care. Saudi Arabia and the United Arab Emirates are the two states which have had these systems in place for a while. All the Gulf states are moving to these systems. The intention is to make healthcare more available to the general population. Our research indicates problems with that argument, looking at what's happened in the UAE and Saudi Arabia and suggesting that actually private health insurance might serve as a further barrier to care. So I'm going to stop talking now because I'm delighted that we've got so many people on from our partner organizations to talk about this issue. All these partner organizations are working within this coalition, but also working independently on this issue. And so each of them has license to take this issue and to advocate on it in their home countries as they see fit. So everyone has a slightly different take on this. And I think that's one of the great strengths of the problem, that not everyone is we're not advocating internationally, although we are doing that as well, but everyone is advocating on this issue domestically, focusing on the issues that are relevant in origin countries. So we've got representatives from all of our partner organizations. We also have our junior researcher, Rhea Arora, who's going to talk about private health insurance. And we also have Usman Javed, who's a consultant working for us in India and who's doing some fascinating work there on this issue. So we'll kick off with, now, did I get my order of people right? What did I say? I said we would go for Roshni first, Roshni Giri from Lapsoj in Nepal, who's going to present next. So I will stop sharing and hand over to you, Roshni.
Thank you, Nick. Hi, everyone. My name is Roshni. So building on what Nick just shared with all of you, I'm just going to talk about what's happening in Nepal. So I'm just going to be case specific. So a few months back, I interviewed a migrant worker whose name was Ludasuna. He was a 33-year-old healthy man. I'm saying healthy because he cleared the pre-departure health screening from Nepal. So he was considered healthy enough to work in Qatar. So he went to Qatar to work as a garden cleaner, whereby he completely lost vision in one of his left eye, and his vision on the right was deteriorating. So he was continuously exposed to the sawdust because he had to work simultaneously with the people who are chopping the trees with heavy machineries. So, but he did not have access to any kind of safety gears like goggles or gloves or anything. So because of the fact that the sawdust was continuously going inside his eye, he started having itchy eyes. His eyes started getting red. So he showed me some pictures and it was brutal. So his left eye looked as if it was going to bleed anytime. So he did not have any access to safety gears and any dresses or anything. So because of that, his health started to deteriorate. His continuous ordeal and deteriorating vision was ignored by the company he worked for. He approached his foreman, he approached his manager, but all of them said that if you want to get a health checkup, if you want to do something about your health, then either you take up on your own, go to the medical on your own, or it's just that you're making issues that you don't want to work. So it was ignored and he did not get access to healthcare, leading to his hospitalization because his eyes got really bad and he was hospitalized for more than 15 days. Though the company covered his hospitalization, he said that even after he was discharged from the hospital, his situation did not improve. Ludra's case is a classic example of how the failure of the companies in the destination countries has created a condition where the workers' health are expendable at the behest of the benefits of the company, because the company saw that he was in a deteriorating health. And one of his friends suggested that he should pretend that he's passing out. So the company would call for an ambulance, because that was the only thing, that only if you're dying, the company would take it seriously. So he pretended that he was passing out and his colleagues called for the company's managers. And then they called an ambulance and he was hospitalized. The company, even after he said that he was not able to work, because once he was discharged from the hospital, like I said, he said that he was not getting better. So, and he said that he wanted to go home because he couldn't work anymore. But the company did not arrange for his return and said that if you want to go home, arrange it on your own. So he was not able to return because he had not worked for a long time. He was still forced to work a few days a week just to feed himself. So he was not in a condition to work, but he had to work just to be able to feed himself. So the company did not arrange for his return, and he was only able to return home, and where I met him, when a Nepali acquaintance funded his flight. So somebody from working in an organization funded his flight back home, and only then he was able to return home. He told me that even when he was going to the airport, until he flew on the airplane, he was really scared that the company might have done something. He might be arrested in the airport and everything. So he said that it was really stressful for him. So when I asked him why he could not get access to health, and so the most common reason that we all know is that he was not provided a Qatari ID card or a health ID card that is needed to access public health and that is subsidized health. And please bear in mind that he had worked for more than 10 months when he started getting those kind of problems in his eye. So even after working for 10 months, he did not have any Qatari ID card or a health ID card. The company blatantly paid a deaf ear to his repeated requests for checkups because his eyes were clearly visible. Of course, we all know that healthcare is expensive. And when you are getting paid only like 1,200 or 1,300 Qatari Riyal, you cannot go to a health checkup like a private health clinic and afford that. One very interesting thing that he told me that was because he lost vision in one eye, he was even willing to go to a private hospital and get a checkup. But he said that he did not have the confidence to go out of the company because he did not speak the local language. So without an interpreter, you cannot go to a hospital and explain to the doctors and nurses unless they speak English. But Ludra, as a person who comes from a very backward community, he did not speak English as well. So he did not have that confidence to even go, even if he was willing to pay. And when I asked him, why didn't you contact the embassy when you wanted to come back home, like the Nepalese embassy, he said that it was so expensive to travel to and from the embassy that he could not afford to do that. So if we look at the financial cost and the human cost that this kind of failure of access to health causes on the sending countries, because we like to call this the bloodshed money of the Gulf, because we send these workforces, our workforce to these destination countries so that we can make some money so that the lives of these people will improve. But what's happening is the human cost and the financial cost is really high. The human cost is that though Ludra's, but in this particular case, Ludra's vision is improving and he has not lost his both his visions, and even on his left eye, his vision is improving, though it's still blurred. Usually these people who come back from Gulf, so they are disabled or they have long-term kidney disease, like our first reports or like chronic kidney diseases. So there is a loss of working ability of the workforce of this state of origin. We send these healthy men, healthy women to these countries, and we are losing our workforce when they come back unhealthy. So the financial cost is that the origin states like us send human resources to the destination states for economic benefits and growth for these people. So they are seeking better lives. However, due to lack of access to health of the workers, when we send them there, they return home with lifelong diseases and sometimes even disability. This causes additional financial burden to the already poorer states because we are sending workforces because we're poor. So this causes additional financial burden because in Nepal, there is a law that when someone comes back disabled or if someone dies while working in a foreign country, the government pays a compensation to the family. So it's a financial burden on the sending state who are already poor. So like Nick just touched upon the cases of unexplained deaths. So accurate information about the number of Nepali workers in Gulf state is not available because of the large number of undocumented workers as well. And when they die, their deaths are not broken down by the country of destination and nor the cause of death. Like Nick said, almost 50% of these deaths are unexplained. So either they are categorized as cardiac arrest or natural causes. We interviewed few doctors. So they said that the use of terms like cardiac arrest as cause of death does not explain why the worker died there. So it can be one reason to die at the end, but this is not the cause of death. So a senior Nepali doctor from one of the prominent cardiac hospital, he said that timely access to health services could have prevented many of these deaths. If these people got timely access to health, they could have prevented deaths. Another doctor, Dr. Birat Krishna Timalsina, he said that because the destination countries are failing to provide easy access to health, this is a likely contributory factor in the number of preventable deaths that we saw in our last report as well. This is particularly true and particularly high when people are working in environment, when workers are exposed to extreme heat or other forms of environmental condition or high levels of stress that can be physical or mental. So we had a case in Nepal in the Supreme Court that LAPSOS took up, and the Supreme Court said that when the cause of death is unexplained or like it's not clear enough, you should conduct an autopsy back in the country. But there is a huge diplomatic problem if you are saying that you want to reconduct an autopsy when the body arrives in Nepal. So right to access to health is a fundamental constitutional right in the Constitution of Nepal. But due to failure of the diplomatic negotiations and continuous follow-ups when the negotiations actually took place, the workers we send are not getting enough protection and thus coming back home as a financial burden, as a human burden to the state of origin. This is the very problem, the financial problem, because that we cannot afford to provide employment to these people, the financial problems, the financial cost, the very problem that the states of origin are trying to resolve by exporting the workforce, that problem is coming back to us by when these workers are coming back as disabled or when these workers die. That'll be all from my side. Thank you.
Thanks, Roshni. That was fantastic. Ludra's case is really interesting. You know, he is in Qatar, where actually they do actually have certain needs tailored to, in the sense they have clinics out, but in the worker industrial areas. But again, he said he didn't have the confidence to visit healthcare, and he wouldn't be able to communicate with people. So it was really good. And the stuff about the financial burden on origin states, I don't think that can be emphasized enough. And what's interesting again is it's not just death, right? It's injury. You know, how many people are dying? That's a problem, but how many are people going back with these debilitating things that place a burden on the economy and a burden on their families? So thank you so much for that. We're going to move to Sana Farooq from Justice Project Pakistan. Sana, do you want to, are you
Yes.
there? Yeah, okay, great.
I'm here. Thank you so much. Thank you for the opportunity to speak and to see everybody from the partnership again. So my name is Sana Farooq. I am representing JBP here. So Justice Project Pakistan is a legal action NGO. So we mostly work on criminal justice reform, the death penalty, prison reform. But we had a really interesting entry into the area of researching overseas Pakistanis or migrant workers. And this came about because now we've identified migrant workers as one of the vulnerable groups that we want to make interventions for. But this came about because we found a really worrying trend around 2014 when we started litigating some cases of migrant workers who ended up on death row, particularly in Saudi Arabia. And when we started looking at these people's cases, you see that it's mostly people who are from backgrounds where they're the sole breadwinner. They are low-skilled workers, and they're looking for a better life. And due to procedural faults within the home state, they're lured into difficult situations, and then they come into conflict with the law, and they've lost their lives in these countries. But as we were doing our research for this, we tapped into a network of people who are part of the migrant workers network. So they're friends, they're family members, people who are coming back, people who are in prison there currently. And this is the network that we used to speak to about this report, about the conditions that they're facing, or the problems that they face, because whether they're in conflict with the law or they're not, and I think Roshni also brought this up about being scared of being in conflict with the law when you're trying to access some services. I think all of them face some very similar issues, and I'm sure those will be highlighted as we go along. But Pakistan has a really interesting narrative on the migrant worker. So as a country, we really appreciate the migrant worker. The overseas Pakistani is featured in the mandates of our political parties. They're usually including them when they're lobbying for new changes, or their political will as a group is important for the country. But despite that, we don't really see a push for better living and working conditions for these migrant workers. And that is a legal fault as well, because we really don't see a diaspora policy on the ground here. I mean, there have been some in the works, but we never come to them. And that's a real problem in actually improving some conditions. So I know that the case studies are highlighted really well by the report, but just some examples of what we've heard. There's really unsafe living and working conditions, so crowded living quarters. One interviewee talked about 8 to 15 men sharing a room, 3 toilets for 60 men. We've also got just inhumane working hours, so working 12 hours a day, often under surveillance. That creates a lot of, besides the physical problems, also creates a lot of mental pressure. And overwhelmingly, when interviewing these people, we find that there's a real sense that they are at the mercy of the state in which they are working. So not feeling that they have access to the same things that a local would have access to, and really feeling like they have to take what they'll get, and sometimes needing to go back home if they need medical care. For example, somebody who did have health insurance, their request was denied when they needed eye surgery. So instead of getting into either a legal battle or recruiting a person who could actually converse in that language, they decided it's easier to just take the financial hit and go back home for that surgery. And this is someone who has health insurance. A lot of people don't have health insurance either because they don't have the right documentation to access it, or because of the relative expense, I mean, the very low wages versus the exorbitant cost of private healthcare, are not able to access that. And for that reason, a lot of them are self-medicating. This has been a very big problem, and that results in long-term consequences, deteriorating health over their entire lifetime. So really, the situation is quite dire, and I know we'll find examples of this across the region. And I think Roshni also said something that is similar to what a Pakistani driver reported, where he said, if I had services, they wouldn't care that my leg was painful, but they might care if my leg was cut off. So really, they're not able to access even emergency healthcare. And then lack of documentation further limits this. I think being just the fear of deportation if you seek emergency healthcare prevents a lot of people from actually going in to get it. And that's what causes these unexplained deaths, because these are complications that compound themselves. So, I mean, just to wrap this up, I would say it's very important that we start looking at improving the conditions of the diaspora as something that our home states should be lobbying for. So it's very important to, if we acknowledge the contributions of migrant workers to our GDP, and we provide benefits when they return, then it's very important to also lobby for that in the states in which our people are working. And from a policy lens, it's very important to have a regional voice on that, which is why partnerships like this are very useful, because then we can have, if everybody is asking for the same standards, it's the only way that we will be able to provide those standards for each country without banning workers from one country or another as a result. So it's important to develop a regional lens on this as well. I think I'll stop here. Yeah.
Thanks, Sana. That was great. I'm really glad you started by talking about the political climate and how important that is, and in the sense that it's always framed as a positive thing, and very few politicians want to talk about how bad it can be on the ground and how the negative impacts. And then by ending the need for a sort of multilateral approach, I mean, it has to be done that way. You know, individual states cannot stand up and demand better rights for their nationals, or they go to the end of the queue. And I guess that's part of the problem that this project is trying to get to grips with and trying to address. And I'm also, there was you talked about the Pakistani workers. There's a lot of Pakistani workers interviewed in this report, actually, probably disproportionate almost, just the way that the research unfolded, which I think is great, because often the focus is on Indian workers or Bangladeshi workers or Nepalese workers. So it is really pleased there's a lot of Pakistani voices in here. There was a brilliant quote, I think, from the worker who you mentioned, where he said the best thing to do is to either have a serious accident, in which case you will get emergency health care, or nothing at all. What you don't want is a sort of in the middle sort of thing where you're not going to be available for emergency medical care, but nor are you going to be able to access the care that you need to get you back to work. So you end up just taking Panadol or painkillers or things like that. That was a key report, I think, or sorry, a key quote, or a very insightful quote from one people in the report. So I'm glad you raised that, and thanks again for coming on and giving us your perspective from Pakistan. We're going to move next to Dr. Abrar Chowdhury, who's from Rumru in Bangladesh. Abrar, I see you there. I'll hand over to you now.
Thank you, Nick. I think it's a very important project, and we have been working on labor migration issues since the mid-90s. But to the best of my knowledge, we haven't come across anything like this, where it zeroes in on migrants' health issues, death concerns, and which is very unfortunate, because many of us descending countries, we thrive on the remittances of migrant workers, but we do very little about their, you know, the hardships that they endure. And when they fall sick, there is virtually no one to look after them. And it's also, it's a pity that the destination countries who get developed through the labor of these workers, you know, do not recognize the need to put in a system whereby these workers, you know, get at least the minimum healthcare, you know, services when the need arises in those countries. I will start off with a story of one of the interviewees who said that, look, I gave 10 years of my life to this company, and I thought this company was my world, you know, I have never been sick, you know, illness was not a major issue for me, but when I fell sick, you know, the company refused to take care of me. And eventually my co-workers, pool resources, my family back home who are not that well off, they had to send money, parting off some of their landed property. And then eventually I could manage to survive. And later I had to come back home. And I never thought my company would do this to me. I mean, that was his reaction. So this actually captures, like Roshni's story, like Pakistan driver's story. This actually captures, you know, the reality that migrant workers endure in the countries of destination. While you know, the destination countries' main concern essentially is, you know, what is the status of the worker? You know, the national security concern, immigration, employment status. And unfortunately, our countries are also mainly concerned about remittances, you know, upgrading the skills to harness more remittances and put in a few other measures than that. And also to take care, I mean, if you talk about the non-governmental sector as well, I mean, they have not done much better either. You know, they talk about information dissemination, access to justice, and many other things. All are very important, but the health issue of migrant has never been a major policy advocacy issue, at least in our country for sure, and in all likelihood in other countries, in the South Asian countries as well. So in that respect, I think this report and the one before that are very important additions to the discussion about the protection, the large issue of protection of migrant workers, the whole discourse of global compact on migration, whole issue of sustainable development goals, because here in this globalized world, you know, people are moving, but, you know, particularly those who are in vulnerable situations, what is there for their protection when they need the most, you know? And we often see, you know, the people fall sick in the destination countries, and for a host of factors, and this report touches on that, long working hours, absence of rest, exposure to heat, you know, unsafe work conditions, accidents, you know, unhygienic living conditions, whole range of them. And then we have the domestic workers, you know, who suffer from feeling of isolation, feeling of insecurity, just because they don't even have a private space, you know, and the conditions are, those in irregular status are even dire, you know. So these are the things that we talk about. However, when we have a regime in our countries, we have labor migration regimes, you know, but despite this fact, in conducting this research, we found that there is little knowledge about their health entitlements in the countries of destination. There is hardly any insurance cover. Employers aren't taking responsibilities when workers fall sick, as you have heard from other speakers. Missions, you know, our missions do not have the capacity to do anything about this respect. And no less important, there is a propensity in the absence of such, you know, of the services, there's a propensity to self-medicate. So these are some of the issues that face, and we have come across in the course, and which is similar to other countries. And I guess, you know, these countries, the destination countries, you know, have had huge achievements in terms of providing Medicare services to their own nationals. So, and they are many of those countries are now very concerned about their image. You know, Saudi Arabia and others, they're doing away with the kafala system. So I think this is the time we should raise voice about this issue, you know, direct their attention and call for, you know, the proper services that the migrant workers need, including those of health services. I'll stop there. And our countries, instead of attending the fancy global processes and regional processes, such as Colombo process, Abu Dhabi dialogue, global forum, they should, you know, talk about these issues on a concerted way and demand, you know, that our workers are better served. It is their responsibility, because our respective constitution, you know, mandates them that they have to take care of their nationals in the countries of destination. Thank you very much.
Thanks, Dr. Abrar. I mean, the way you summed it up at the end is just the obvious simplicity of this. You know, they're your nationals, and you have to stand up and protect them, and the evidence is there to show show that they're not being properly protected. You sent over, I mean, Rumru, the case studies that you did. There was one, I was glad you mentioned domestic workers, because there was one which just stood out. You had a 35-year-old Bangladeshi widow supporting an 18-year-old daughter and a 13-year-old son, who went to, I think she ended up in Kuwait, and basically just ended up in one of those terrible situations where she was subjected to terrible abuses and was just unable to see doctors and had to rely on the medicine that she brought with her. We have an entire section on the specific vulnerabilities that the domestic workers have, and I think her case that you guys documented in such sort of tragic detail was just an excellent example of that. So thank you, and thanks also for your time and the great work you've done on this in Bangladesh, where I think you've actually been quite successful in getting this onto the policy agenda, right? I mean, there's been some really interesting comments from some fairly influential people in Bangladesh, no?
Thank you.
Thank you. Now, next up is Cristel Sobredo from the Center for Migrant Advocacy in the Philippines, which is a very well-known organization with a tremendous record, and who we're delighted to have on this project with us. Cristel, over to you. You have a presentation, I think.
Okay, yes, I have. Thank you, Nick, and hello, everyone. I hope you are having a nice day. So again, I'm Cristel Sobredo, and I will be sharing with you the access to healthcare system in the context of the Philippines, or the Filipino migrant workers. So I have a presentation, so I just have to set it up. Okay. There. I hope everyone can see it. Okay. Yeah. So I'll just start. So again, I'll just share some recent issues and development in the healthcare system for the migrant workers in the context of the Philippines. So, oops, I digress. Okay, so now there have been developments recently in the healthcare system of migrant workers in the Philippines. So just to mention a few, the government built one OFW, or Overseas Filipino Worker Hospital, which the OFWs and their dependents can access. It's in one of the provinces in the Philippines. And then another one is the mandatory contribution to a government medical insurance, which I will later discuss. So just to look back before in the phase 1 report of this project, although the presence of COVID is already there, most of the illnesses that we were concerned with as a cause of death are more on the circulatory and respiratory, to name a few. The diseases were already known. However, come COVID-19, everyone and everything were shaken, and broken systems were highlighted once again. Based on the Bureau of Quarantines report in the Philippines, so the top 3 countries with the highest number of Filipino migrants who contracted COVID are all in the GCC. Granted, the base populations are also big, so the ratio follows. Still, the number of sick people signals an important issue behind it. So next presentation and the data provided by the partner organizations as well as the speakers for today provided us with valuable glimpse of the reality that migrant workers experience. I agree on the findings that were presented and were shared, and I'll just add some information and context in the Philippines. So as I've mentioned, the COVID-19 unraveled the broken system we have when it comes to the healthcare. So the OFWs we interviewed for this study showed how the programs and services of the government were mostly short-term solutions, such as financial assistance or even loans. And yes, they are functional and resilient, but these are band-aid solutions, and it's already reaching its limit. And then there's also the lack of resources and capable personnel of the government to remedy the situation and assist the OFWs. So what I've just mentioned is not to point out the inadequacies of the government, but to raise the concern that everyone, even the government staff or the groups within, are somewhat trapped in this kind of a system that is becoming inefficient. Okay, so next slide. On the other hand, moving on, there are initiatives such as policies and laws that intended to improve the state of the healthcare system for migrants. However, good implementation remains a challenge. So for instance, to relate to the privatization of healthcare system in the GCC, the Philippines also mandated the OFWs to have a PhilHealth insurance on top of their existing insurances and other bills or payments. So under the Universal Healthcare Law, OFWs earning 10,000 to 60,000 pesos or $174 to 1,000 something dollars are obligated to contribute 4% this year of their salary to PhilHealth. The alarming part of this scheme is the increasing rate of contribution or premiums based on the salary. So the 4% will increase next year, become 5%, and so on and so forth. So and then this is not paid by their employers. So the employers are not obligated to pay for it. So it's 100% should be paid by the OFWs. So the mandatory PhilHealth insurance was presented as a way for the Filipino families to weather medical related problems, which is good. Everyone should have access to good healthcare system wherever you are. So however, not all the migrant workers earn handsomely. We should already be given. And yet, this law imposes punishment for those who are incapable to pay diligently, regardless if you are low-wage earner. So they impose interest rate based on the duration you fail to pay. So instead of having a universal healthcare law, which works under the concept of solidarity, it became punitive. And this is a great blow to low-wage earners, which are mostly women. So that's on the part of the government. Now, on the part of the OFWs, as this research also found out, the access of the Filipino migrant workers is also reliant to the decision of their employers or their agencies by the virtue of the law. And not only is this restrictive, but also divisive in terms of document or whether or not you are documented or undocumented. As for the second point, in terms of desperate situation, there's a heavy reliance on the compassion of other people and the urgency to sought after the government offices. So which is both good and bad. So good in the sense that there's still humanity present, but it's bad because there's a tendency for this practice to push the migrant workers to become more passive and settle for less. So there are participants we interviewed and they are very thankful for the people who helped them. But when we ask them if they have recommendation or comments for the institutions, they do not have much to say. And given the migrant workers who acquire diseases, their priority is to recover and continuously earn for their families. Getting sick is just some sort of a life event which they need to overcome. And in other cases where they want to address the issue of accessing healthcare system, those who are very vocal, migrant workers themselves, however, they are faced with a problem that of the realization of how little power they have against the structure, against the system. So there's also, last point, there's also the problem of portability or transferability of healthcare access. So the reliance on the employer and country of origin is also because of the underdeveloped portability of benefits earned by the Filipino migrant workers in the Philippines. So they do have social protection schemes here. However, they cannot really consume it in the countries of destination efficiently. So that's one of the problems as well for the access to healthcare. And then, okay, so I just have to wrap things up. With all the challenges and difficulties, this is where we, the CSOs, the migrant groups themselves, international organizations, and even the academe should enter, or this is where we increase our engagement. Moving on to some of our recommendations, we hope that we continue to push for a participative and transformative approach to addressing the issues of access to healthcare system of migrant workers, such as how divisive and unfair it is for migrant workers in terms of those with different jobs, wages, and especially in terms of gender. We need to engage everyone in every level as much as possible, so be it individual, institutional, national, international. Okay, so and then there's also the need for providing continuous provision and monitoring of data regarding the topics, since these are very useful. And we can also move it forward and use the data to address the issues on the legal frameworks of the GCC countries. And of course, we continue to lobby our advocacy for migrant rights protection, legal, social, and general protection, which includes, of course, the accessible healthcare system. Thank you. I hope that's been clear.
Thanks so much, Christelle. That was great. One of the it's interesting. Filipino workers tend to get better protection, slightly better protection than others, because the Filipino government is more active and has a better bureaucracy on the ground in the Gulf. And I think that came through a little bit here, but still we had lots of cases of Filipinos who suffered quite terribly. One of the things that kept coming through in Filipino cases was the sort of mentality that we can survive this, like we're strong, we know how to suffer, we can accept all of these things because we provide for our families, and how that can be such a harmful attitude. I mean, on one level, it's very admirable that people are prepared to put themselves through such sacrifice for their families, but the impact on their physical health and the impact on your mental health, again, reference to a case of a domestic worker who was clearly suffering from mental health problems and had just given birth to a child, but felt this pressure to keep going despite the terrible abuses that she was suffering at the hands of her employer, came through really strongly in the Philippines. So again, thank you for all the amazing work you guys have done on this to date, and for the presentation. We're going to move now to two final participants. Sorry, there's a lot of participants here, but there's a lot of different voices here and a lot of origin states involved, and we wanted to make sure that comes through and that each perspective is brought into this, because they're so important. And it should be the origin states where this conversation is most robust and vigorous. So our next speaker is Usman Javed, who's a consultant who's working for Fair Square and who's looking at the situation in India and has done some really fascinating research to date. Usman, are you there? If so, I will hand over to you now. Thank you. Off you go.
Thanks, Nick. Thanks. Thanks, and thanks also to all the other participants. It was great to listen to everyone. While listening to them and also while reading the report and the conversations that led up to the report coming out, a couple of things struck me. So I thought what I'll do is I'll take a step back and look at a couple of things that I think enlarge the scope of this conversation a little bit. So the first thing that I wanted to talk about was the commonality of this challenge, right? Access to healthcare. It's a challenge even in the sending countries. Challenge for working people even in India, and I'm sure it is the same in other countries where other participants are speaking from. So speaking from the context of India, quality healthcare, access to affordable and quality healthcare is a substantive demand in India, right? It's been raised by the public health campaign. It's raised routinely by social movements and by labor unions, activists, etc. And one can another thing that is kind of like a parallel between something that the report talks about and what we see in India is like one can very clearly identify the push towards health insurance. In the case of India, the cost of expanding public investment in healthcare being the approach of either state, and right, its failure in India in making affordable healthcare accessible is very evident. So we've got the regime now introduced a health insurance model, right, for below poverty line families, and that the outlay on that is a flagship public health scheme, right? So the outlay on that has primarily ended up benefiting private hospitals, while private health insurance remains out of the reach of the majority. In a country where earning 25,000 rupees puts you in the top decile of income earners, right? So then again, about 70% of healthcare provision in India is done through private operators, and this trend has been on the rise Out-of-pocket expenditure for healthcare on healthcare in India is among the highest in the world. It's around 50%. It used to be around 70% at the beginning of the century. It's come down a bit, but it's still above 50%. And if you add the private insurance to it, it increases, right? And this is despite low wage levels. And with the pandemic, there's been a decline, of course, in the wage levels and an increase in health expenditures. And there are very scary estimates of how many families will be pushed into desperation and poverty because of this. Basically, you're one accident away from destitution, so to speak, right? And unfortunately, that's not a rare occurrence. So even the place where I stay in Bombay, near here, there is an industrial belt in Boisar and Palghar. Every week, one hears of industrial accidents. In Delhi, you routinely hear about it, etc. So it's not uncommon. And this is despite the fact that healthcare is a booming business in India. So if I'm not mistaken, since the first decade of this century, healthcare has seen about 100-fold increase in foreign investment. Right? Of course, it's a low beginning mark, but clearly shows that there is an increase, right? And especially in telemedicine and digital health, etc. Okay, so but what happens is a couple of things, right? So working people are just not used to being provided for when it comes to healthcare. It's in terms of, and because Nick, you were talking about attitudes of workers coming across in this, it's a result of these structural factors. It's also that, right? You've never experienced it. So even in sending states. So to me, what the report shows that in the Gulf, despite high quality care being available, workers can't access it, right? And the peculiarity of the labor regime in these countries, added with social discrimination and low wage levels, etc., is what ends up denying these rights, right? It's, again, to me, it speaks of a way of disciplining workers, right? In an impersonal, structural sense when one thinks about it. So, and in India, not a parallel, but if one is to think around these lines, one will have to think about the formal and informal divide, right? In the Indian labor market, where a small minority can claim benefits via employers thanks to being covered under labor laws, which are being rolled back presently, and most can't, because they don't come under explicit, well-defined labor laws. So the employer-employee relationship, to establish that, becomes a problem. Therefore, they're not mobilized, and they don't seek these rights as accruing to them because they are value-creating workers. You know, they have to be mobilized as citizens, but the underlying basis of the thing remains the same. So I mean, that's just to broaden the context, to bring in also the conditions that one sees in sending states. And the other thing that I wanted to speak about was when it comes to recommendations, and everybody's spoken about the challenges and what needs, and the responsibility of sending states as well to act in order to ensure that this doesn't happen. Even the Indian state has, in '95, we had a case in the Supreme Court of India, which basically read the right to health of workers into the right to life in Article 21 under the Indian Constitution. So even if you're working abroad, as long as you're an Indian citizen, the Indian state has an obligation towards you. And also, you're working abroad under conditions which the Indian state has a say on, right? So the Indian state does have memorandums of understanding with all of these countries. And one of the recommendations is to include proper healthcare for workers in said memoranda. But what makes it impossible? What will make the implementation of this happen, right? And that is the question that I want to just end by flagging. What is the vehicle through which you basically raise these demands in a way that to raise them and to raise them effectively, right? Which means to have them be actualized. And despite this slightly grim picture, right, very grim picture that I painted, we also have examples of successful mobilization of workers who would otherwise be considered marginal, like extremely marginal to the economy, to the society, etc. But whatever basic social protections we have, in the sense of the right to food, in the sense of the right to work, which is the NREGA, the right to food, which is the National Food Security Act, as well as civil and political, the prime example of civil and political rights in India, the right to information, right? All of them came about because of mobilization of people who would otherwise be considered really marginal and powerless and on the margins of Indian society. But it is through collective action that they could get constitutional guarantees for basic securities, which working people in this entire country enjoy, or at least formally enjoy. But to make it work every time, you require collective action. So even the public works program in India works well, where workers are organized enough to demand those, to demand work, then to demand timely wages, then to demand remuneration in case they have to wait for those wages, etc., etc. So the key challenge in that sense is again collective action, right? Even if you have like very good policy solutions, to have them actually be implemented and be effectively implemented, you require collective action, and that challenge gets really highlighted in the case of the Gulf countries, because in many of them unionization is not allowed. Collective action faces structural barriers, I mean, or is simply outlawed, and therein lies the kind of conversations that we've been having in India. And I know that I'm saying all of this also because it resonates with some of the Indian participants that I see here, and hopefully with others as well, that there is a pressing need to collectivize these workers in India and in other sending states, and to then have strategic action across sending states that puts pressure on their countries in order for that part of the problem to be fixed, right? That the sending countries take some responsibility. That's just one part of the problem, but to fix that, you require collective action in sending states and a strategic kind of coming together of workers from different sending states. So I'll leave this here just now, and hopefully you can return to it in questions.
Thanks, Osman. And yeah, very grim picture, but talking about collective action is, that's absolutely the answer. It's the answer domestically in each regional, in each country context, and it's the answer regionally. It has to be collective action. So that was then nice to end on a sort of semi positive note. Thank you very much for that. I'm just going to quickly go to one of the questions that came up. Someone asked, is there documented research regarding, Rajan Sharma asked a very good question. Is there documented research regarding how many migrant workers had health insurance, what sort of items they couldn't claim, and so on? So which is a perfect segue into our last speaker, who is our junior researcher, Rhea Arora, who did some tremendous research on private health insurance that I'm really glad we've done. And of course, this follows on from what Usman was talking about in the Indian context as well. So this is a perfect segue into Rhea's chat. Over to you, Rhea, and I believe Susie for the slides.
Okay. I will answer the question hopefully after, or if it's not already answered with the presentation. But yeah, so I will be speaking pretty specifically about mandatory health insurance schemes in the Gulf. Next slide. So why are we talking about these? Well, because all of the GCC states either already have a scheme in place or they're in the process of implementing them. So details of the differences aside, basically, these schemes make the employers or sponsors responsible for purchasing health insurance for migrant workers in the private sector. So they transfer the cost of healthcare to the employers and insurance companies. Next slide. So why this change? These are just some theories. Universal health coverage. So you force employers to pay, you reduce workers' out-of-pocket expenses, and you widen access to health. But obviously, whether this is an improvement also depends on what your starting point was. So for example, it's not clear if the shift from a health card-based system, which gave documented workers access to free or highly subsidized healthcare for about $27 in Qatar, to an insurance-based system really improves the system in the way that it probably does improve the system in Oman, where workers pay market price for all non-emergency care currently. The second reason, privatization. So the implementation of insurance schemes has coincided with an increase in the privatization of healthcare services in the Gulf more generally.
and falls in the price of oil. So it's meant to transfer costs away from the government and mitigate dependency on oil and gas-based revenue. So basically, there's a sustainability and diversification angle here, notably in the absence of income tax revenue. Quality and efficiency. So insurance schemes will tend to cover private services. So the thought is that in virtue of market competition and private investment, they will increase quality and efficiency, although there is research to suggest that doesn't actually happen. But importantly, they will also decongest, and this is what national visions will often highlight, decongest the public hospitals for citizens by relocating the migrant worker population to private clinics. And you might think that the decongestion point in particular is to appease the national population, because there are polls to suggest this. So for example, in 2011, 75% of Qatari respondents said migrants were a burden to national health services. But there is a reason to be skeptical about these, because, next slide. Because it seems like it isn't as linear as nationals want X, so government gives them X. Sometimes, and what's on the slide right now, a 2016 migrant-rights.org article notes this, there's even a concerted effort by the government to generate support for X. So the article notes, during 2013 to 2016, the Health Ministry of Kuwait, with the help of the media, popularized a discourse to support their claims that segregation, so the relocation of migrant workers to different clinics, will afford Kuwaitis the best care. This included blaming expats who make up 2/3 of the population for long waits in hospitals and clinics, despite the fact that Kuwait's parliament and politicians have publicly and regularly criticized the government for failing to reform or meaningfully expand health services since the 1970s. So the problems in Kuwaiti healthcare have preceded the influx of the migrant population. So this effective scapegoating of migrants has the effect of absolving the government of responsibility and provoking anti-migrant sentiment, not least to the effect of, like Usman was saying, undermining the possibility of collective action, which, as Usman was saying, is super important. And scholars have previously spoken about public healthcare facilities representing an increasingly rarer interstitial space in which citizens and migrants converge and complicate the boundaries. So the crackdown on these spaces is not political, in my opinion, which is all to say, we need to be skeptical of giving too much airtime to narratives that pit nationals against migrants in this way, because it's too convenient, and we need to think more about the role of political assurance and legitimacy in all of this. Next slide. Oh, great. So here's what an advisory group of Kuwaiti doctors, the Healthcare Reform Advisory Group, who were consulted about these changes, said, cautioned in 2011, which is that, I'll just hurry up for time's sake and end with what they said with the last sentence, which is that contrary to the way this has been marketed by its proponents, this scheme, the health insurance and the reforms, is in obvious violation of basic human rights, is not financially viable, and will not result in high quality services. Next slide. So Dubai and Abu Dhabi have had insurance schemes, and Saudi, but this research is to do with Dubai and Abu Dhabi, have had insurance schemes in place for a while. So we do have some studies to evaluate their impact. I won't read what's on the slide for lack of time, but essentially, if there were any positive effects, including the increased use of health services, they weren't replicated in the case of low-income migrant workers. So their relative disadvantage increases as a result. Next slide. I suppose what I want to highlight is that there is little to suggest that these health reforms have been undertaken with migrant workers in mind, who, by the way, make up the majority of the GCC population. And it's well put by the Systematic Review of Healthcare Reforms in the UAE, which notes little evidence to show that there has been consideration of things you would think would be major points when planning and implementing health services, given the migrant worker majority. Indeed, the health data to do this is just not collected and reported. And we could see this in our own primary research. So about 67% of respondents in our Kuwaiti survey said that the care that they received in Kuwaiti hospitals was of good quality. So the problem wasn't a lack of provision of care or poor quality of care in the current system, but quality and best care is what seems to be most explicitly referred to as reasons for reform. Yet it seems that that's not the problem facing the majority of the population. So it's either a misdiagnosis of the problem or a failure to address it. In either case, it's negligent. Thank you.
Thanks so much, Ray. And you did so much research on this, and we could only include a fraction of it in the report, which was disappointing, I guess. Which was our decision, because it was so rich and so detailed. But hopefully we'll be able to do that at a later date. Yeah, I mean the issue of health insurance. I mean, health being sort of a revenue stream for the Gulf states. Not only that, but certainly something they've identified as a potentially post-oil revenue stream, rather than being a government responsibility to primarily a government responsibility to deliver healthcare services and to deliver health to people, is something that I think is deeply problematic. And your research was really helpful and was key to our analysis of private health insurance. So thanks for the presentation and for all your work on this. Right, well, that almost brings us to the end of this. I'm going to, I've got one question which I want to quickly deal with. Becky Mitchell made a really good point about looking at asylum seekers in the UK who are struggling to have access to healthcare there, you know, and the point being that, you know, this is a universal problem. And I think that's absolutely right. It would be wrong to paint the Gulf as truly exceptional when it comes to a lot of these issues. I think where the Gulf stands out, though, is perhaps the scale of the problem and the severity of the problem. So it's millions and millions of workers we're talking about, which is not in any sense to downplay what's happening. The appalling UK treatment of asylum seekers is just horrendous. So it's not surprising to see that comment from Becky, but pretty distressing. And Becky, I'd love to hear more from you about that work. So please do stay in touch. I'm going to end though quickly by asking each of the panelists to quickly give us, if you had one recommendation, one thing to say to an origin state government, you know, to your own government on this issue, because that's where we want to focus a lot of the attention, what would that be? And I'll give you we've got 5 minutes left, so interpret that as broadly as you like. I think we've lost Sana. I'm not sure we have Roshini. But let's go to Abrar, if you're there, Abrar, and then we'll go to Usman, and then we'll go to Christelle, maybe. Hey, Abrar.
Hi.
Yeah.
Well, I would say, you know, stand up for your own people, you know, and make in bilateral negotiations, you should insist on explicit clauses, you know, which mentions about their entitlements on the health front. Health service.
Thanks, Abrar. Yeah, those bilateral agreements tend not to get. They can be a little bit weak in practice. Sorry, my doorbell is ringing in the back. My son has just come back from the swimming pool. Let's go to Usman. Usman, I mean, if there was one thing that you could say to the Indian government on this issue, I mean, what would that be for you?
Follow the Indian Constitution. It guarantees access to healthcare for workers even post-retirement. So if they were working outside but working in conditions that you have approved of, then ensure that they have access to these conditions. And a second one, more concrete one, beef up your embassies, have people who can respond to emergencies and to crises that are reported.
Well, that's a perfect segue to the one country that has beefed up its embassies, which is the Philippines, but whose record is by no means exemplary, I wouldn't say. Christelle, anything from you on what would you be saying to the Filipino government on this issue?
Okay, just to share, we actually have a newly established Department of Migrant Workers, which will entail another administrative, bureaucratic, and possibly systematic change in the migration governance in the Philippines. And hopefully, with the future ahead of us, the government, or at least the Department of Migrant Workers, would ensure an effective implementation of policies and laws, since the duty of the state is to protect its subjects and of course, it's the migrant workers. But also to add, they should also empower them. In terms of the access to healthcare services, we hope that the government would encourage the migrant workers to actively access the healthcare services that are available to them.
Thank you, Christelle. Thank you. Very clear. And Rhea, I know you're not technically part of a partner organisation. You're a Fair Square researcher, but what would your recommendation be? I'd be interested in your thoughts. Yeah, you're muted.
Okay. I think I would look for possibilities of collective action in the destination countries. Obviously, for context, I grew up in Qatar. And so this is very close, but I am Indian. I'm currently in India. So this is close to home. But yeah, I would look for cross-citizen, non-citizen opportunities of collective action, because I think that's a point of, you know, there's a concerted effort by the government to stop that kind of thing. I mean, in the 70s, they moved from Arab-speaking workers concertedly to South Asian workers so that there wouldn't be a kind of space for shared language, shared culture, shared religion. So that there is an effort here that if we can kind of, I don't know how we would do that, but, you know, collective action, that would be my recommendation.
Thank you. That's a pretty solid one, and seems to be, again, that's what this project is about. Really, it's about trying to generate that collective action and to give people the information, the evidence, and the recommendations they need to make that effective. So that's a good note to end on. Thanks everyone, all panelists, all researchers, everyone who helped in this research. And there were a lot of people who did and who haven't been able to speak today, and we're hugely appreciative to all of them. One final thing to say is the website for this is now up. It's at vitalscienceproject.org. It includes both reports. It includes executive summaries of the first report in Hindi, Bengali, Nepali, and Urdu, I believe, if I'm not mistaken. And the second executive summaries will be up soon. So that's something that we're delighted to announce at the end. There's a lot in these reports, which is why these webinars are jam-packed. It's difficult to do it any other way with a project like this, where where it is organizations from South Asia and Southeast Asia that are part of this, and we need those perspectives coming through. So thank you for your patience. Thank you for your time in coming and listening to us, and please check out the website because there will be more to come. There's a third report coming next year. But we're going to just take a little pause now. Okay, so thanks to everyone and take care. Oh, we've got one more Q&A. Let me just check. One more Q&A before I close. Oh, it's just Becky's email address. Got it, Becky. Super, we'll be in touch. Okay, take care, everyone. Thank you. Bye-bye.